I have really the honor and the challenge of moderating this panel, and I say honor because we have some really great expertise, wisdom, and experience on this panel. The challenge is we only have 45 minutes, and so we have a lot of ground we're going to try to cover. I will introduce the panelists, and then they will each take some time to talk to a little bit more detail around our topic of prescription and pain management and the pathway to addiction. Let me just say, as I said, we are going to have a few slides, and hopefully we might even have some time for questions. We'll see. On my left, I have Dr. Daniel Doles, who's the director of Doles Clinic Pain and Rehab Institute. Just on the other side of Dan is Greg Ayers, Dr. Greg Ayers, who is the president of the Jefferson County Medical Society. Just on the other side of Dr. Ayers is Scott Daniel, who is an investigator with the Alabama State Board of Pharmacy. On the far side of Scott is Edwin Rogers, who is an investigator for the Alabama State Board of Medical Examiners. And on the far side is Jerry Harrison, who is Dr. Harrison is with the Alabama State Board of Medical Examiners. And we're going to start with Dr. Doles.
I appreciate the opportunity to be here and have just a few slides to cover some of the characteristics or aspects that we kind of face in this issue of prescription medicines and whether or not they do in fact lead to heroin. This first slide is somewhat of an interesting one because it goes from 98 to 06, and what it does is what we sometimes don't see or think about is the media coverage. And in this first panel, you can see the frequency of media coverage for fentanyl and for Oxycontin, and over the years how that accelerated. In the second panel, you see mortality. And the content of the articles was not analyzed. All the authors did was ask a simple question: is there a relationship between the frequency of which there are media coverage and articles and mortality or use of the drugs? And indeed, there was. This is somewhat of a continuation of what Deputy Attorney General Cole noted. And in the right-hand corner, if you can read it, it notes that non-medical users of prescription pain relievers were 19 times more likely to initiate heroin. And when they talked about people who had recently started heroin, they were 4 to 5 times more likely to have used prescription drugs in a non-medical fashion. So where did they come from? And there was a separate study that looked at 12-year-olds and up. The study noted that when you look at a group of 12 to 17-year-olds and you ask them, that 3% of 12 to 17-year-olds will tell you that they have used prescription drugs, non-prescription fashion, the month before. 3%. Where did they come from? Well, the vast majority, as you've already heard, come from family members. So they come free from family members or friends, 55%. 11%, they're bought from a family member or friend. 17% from one doctor. And if you look then where family and friends are getting them from, some 80% come from a prescribing physician. So they're being prescribed, they're taken home, they're set in the cabinet or the cupboard, and then you youth find a way of getting to them. So what is something that the pain management community, and I've been involved in pain management in 35 years, and when I talk about pain management community, I'm referring to anyone who is prescribing medicine, particularly opioids, for the treatment of chronic pain, particularly on a long-term basis. What are some of the things that we in the pain management community can do and should emphasize that may help to address the problem at hand? One of the things is that we can adequately assess for risk. What is the risk that a patient that you're prescribing for will manage these drugs or not? What's their living arrangement? How responsible are they? What about cognitive functioning? Some people have TBIs or dementia, and they're not likely to manage the medicines well. Stratify treatment based upon risk. One should do an assessment of the patient, and some patients are going to be at higher risk than others, and they should be treated accordingly. Some patients can be seen every 2 to 3 months. Some may need to be seen every couple of weeks until a pattern of compliance is established. Use of non-drug therapies, and unfortunately it's easier to use drugs than it is non-drugs, and from an insurance standpoint, many of the evidence-based treatments that have been proven to be most effective with chronic non-cancer pain are not covered by many insurance coverage. So logically, patients go in and the first thing they ask for is that covered under insurance? What's going to be covered? And our tendency is to treat according to coverage rather than necessarily what might be the best therapy. Use of non-opioid analgesics. There are many types of medications, including several antidepressants, that have analgesic value. One does not have to retreat to the use of opioids. Control the monetary motivation. There are some who treat according to how many they can treat and according to the monetary motivation. We have to monitor adequately. Pill counts, locked dispensers, drug screens, having significant others come in, prescription drug monitoring programs. Patients must be monitored on a regular basis for any abuse, misuse, or possible diversion. The focus should be on quality of living and functioning and not on pain. The research is very clear, and that is addicts will never come in and tell you they are better. They will never come in and tell you they need less medicine. And if we learn to focus on whether or not the medicine helps quality of life rather than a subjective measure such as pain, we're more likely to have better outcomes and maintain patients who are deriving the benefit from the medicines. One has to avoid being codependent and unassertive. I do a number of lectures throughout the year to physicians, and there are some physicians who unfortunately have a difficult time saying no. And usually one of the last slides I put up in these talks is, don't say yes if you can't say no. Demand security of controlled substances. There should be an insistence that these substances are locked, secured, and if somebody is not responsible enough to keep them from being stolen, then they probably should not have them prescribed to them in the first place. We should emphasize using the most tamper-resistant and least abusable drugs. And there are some out there, and of course, if you look at the heroin use, all you have to do is go to 2010 when OxyContin put out the more tamper-resistant, and you can see a dramatic escalation in the use of other opioids and in use of short-acting once OxyContin changed its formulation. There are guidelines, and they're not demands, but there are guidelines, and we need to rely on and execute the guidelines that are out there for proper prescribing and management in this kind of a setting. And we need to avoid treating according to insurance guidelines or patient wishes. Patients oftentimes have a sense about what they will work, but it's not the only thing that will work. And as I mentioned earlier, sometimes we treat according to the insurance guidelines rather than according to what might be the most effective treatment for the patient. This is a cartoon I show frequently, and here it is. You must learn to cope with your problems like an adult, and the child says, "Oh, you mean I get to take tranquilizers?" We need to have a bit of a cultural and a societal revolution. Pain is not an opioid deficiency. Life is not a chemical deficiency. We have a tendency through better living, through chemistry, all one has to do is watch the media, watch television, and find the last time you uncovered a commercial that says, if you have a headache, you might think about relaxation, stress management, proper diet, exercise, wellness behavior. That is not what we see. We see you need to take X, Y, Z, the blue pill if it's here, and if it's back here, it's the yellow pill. So part of this is having to change and starting to change early, that there are other ways of coping with stresses, of dealing with life, and especially the young kids. They're exposed to things that most of us in this room, certainly when I was growing up, never exposed to. They need help. They need us to be role models, and they need to learn how to cope in other ways than through chemistry. Thank you.
I'd like to thank y'all for asking us to come. I'm the president of the Jefferson County Medical Society. We're composed of about 2,200 members here in Jefferson County. We're the largest medical society in the state of Alabama. And when we heard about this, you know, our board discussed this at our last meeting, and we were very concerned about our prescription drug epidemic and the rise in heroin use in our community. And just thinking back to medical school, over many years and talking to my colleagues, really our fear has been really under-treating pain or under-treating people that were dealing with suffering. And we were taught to kind of look at pain as another vital sign. Were people in pain? If they were in pain, they needed something to help that. And, some of the comments were made about, we really need to look at acetaminophen and other analgesics first instead of first turning to opiate medications. Well, has this prescribing habit subsequently led to diversion and dependence? I think we probably can say yes to that. Our state BME has been very proactive in creating new regulations and tools to aid the physicians in identifying individuals at risk for abuse and subsequent diversion. However, those that are addicted now may need to be affected by these new rules and regulations. These restrictions are necessary and most certainly will prevent new people from being opiate addicts and developing opiate addiction. However, there are untold numbers that are already addicted who really need access to treatment. So I believe, treatment is something that we really need to focus on for those that are already addicted. Just cutting down on the number of prescriptions written won't do anything about that. So if we stop additional prescriptions from being written, then there's no access to legal sources of opiates. Then the current addicts may turn to the black market. If there are no pills available on the black market, which are having to be imported from other states or other areas, then they're going to look at something else, and that is heroin. So whatever we do, we must be careful also to not be overly restrictive in our efforts to avoid the risk of undertreating pain. I work with palliative care and a lot of people that are on hospice and have end-stage life and really cancer and things like that. And I see in the hospital really under-treatment of pain in the hospital setting many times. Physicians are afraid to treat pain. And that's what we're seeing. I think some of the new regulations have led actually to some physicians being afraid to actually give prescriptions for pain medicines when they're actually warranted. So we have to be careful with that as well. But in summary, our society is very interested and very encouraged by meetings such as this, and we're certainly willing, from our standpoint, we're willing to host and convene at our office or at our facility a session, if we need to conduct one, to address the overprescribing of controlled substances and develop strategies that have already been outlined that need to be employed by our physicians. It's something that we need to do for our patients and that we need to do for our community and really for our families as well. Thank you again for coming. Thank you for having me as well.
About 3 years ago, I was speaking with a friend of mine who's a narcotics investigator in Montgomery, and we were just having a conversation, and he mentioned to me that he said, crack's not the drug anymore. And I looked at him and I said, what do you mean it's not the drug of choice anymore? He said, we're hard pressed to find it on the streets now. We're finding more heroin. Well, I just blew him off. I thought, well, I work for the pharmacy board. We don't deal with heroin. We don't have, Well, it does strike in the world of pharmacy. Our pharmacists have to deal with addicts. I would say it a lot on a daily basis. Unfortunately, what I've come to find out is our pharmacists just aren't adequately trained to deal with addictions. For the most part, what I'm finding out is they only receive a couple of hours of any type training in pharmacy school. And I think that's sad, but at the same time, I also feel like they're being pushed just to get numbers out, to get pills out the door. I have pharmacists all the time asking me, when are they going to put a cap on the amount of prescriptions one pharmacist can fill in a day? And I said, I don't know. I don't think it'll ever happen. And they're almost begging to have some type cap put on this. But heroin's come back. And one of the speakers earlier spoke to this point that how many of you are familiar with the pill mills in Florida, all that situation? Well, that cut off a lot. We were bombarded in this state with calls asking us, can we fill this? We call the doctor's office. Well, we come to find out these doctor's offices down there would hire just secretaries from temp agencies to sit in an empty room with a desk and a phone and say, yes, we authorized it. Doctors were setting up tents in their parking lots. People would drive through, pay their money, and hand them a prescription. They were going by the bus loads from Ohio, Tennessee, Virginia, Kentucky to get their prescriptions in South Florida, and then they would bus back. But that situation with the pain centers in South Florida cut out a lot making it to the streets. Then there was reformulation of OxyContin, which has been mentioned here today. It's in the same class as heroin. It's an opiate. They reformulate it where it's not as easily crushed and can't be snorted or injected as easily. So that they're looking, as mentioned before, they're looking for that high. A lot of the drugs have been reformulated. They've clamped down on it, so they turn back to heroin, which has never really gone away. It's always been there. But our pharmacists they want to do right, and they try to do right. But I assure you, there are 6 of us in the state. That's it. 6 of us cover the entire state. We are swamped. We not only work diversion cases involving pharmacists and technicians, we have to handle what I consider minor complaints, basically customer service type issues. If they complain, we have to investigate it. But if we find one of our pharmacists filling prescriptions that they know was not legitimate, not for a legitimate medical purpose, they have a duty. If they breach that duty, I promise you, the Board of Pharmacy will be there. We, and along with the medical board, we work closely with these guys. We work with them quite often. We have a very good relationship with them. We will do whatever we have to do to not only have you before our board, but we'll seek criminal prosecution. But anyway, I'll turn over the microphone to Mr. Edwin Rogers.
Just to clarify things, the Alabama Board of Medical Examiners is over the licensing of physicians in the state. We're not like Dr. Davis. We don't do autopsies, okay, for any of y'all that did not know that. So we're sort of, I would say, on the front line, whether somebody steals the medication out of a medicine chest of a family member, it was originally written by a physician. I got to thinking earlier while Chief Roper was up here. He said that he was at 3 law enforcement agencies. One of those was Montgomery Police Department, where Scott and I both worked. I retired from there. And I got to thinking about some of the stuff, and about half my time there was spent in narcotics. Don't know that I saw heroin once or twice during that entire time. It was always crack. But there's something different. Number one, this is deadly. What we're talking about here today is horrible. Listen to those families was just tragic events. But there's something here today that we didn't have when I was working this stuff. One, a group of people this size meeting to talk about ways to combat this epidemic. And that's the first thing that you've got to have in anything that you do as far as some type of enforcement, and that's communication. Communication between different agencies, communications between education and medical and pharmacy. There's got to be communication. And I'm here to say that Clay Morris was here from DEA, and he didn't mention it, but there's a tactical diversion unit that's in Birmingham now that deals strictly with that type thing. That's something that we didn't have years. That's a tool that we didn't have years ago. Diversion has been around, I guess, since the first prescription was written. I don't know, but I know when I was with the police department, there was a problem with diversion and diversion medications, and that's still a problem. And that's sort of where we come in. And talking about the communication, something else that you have right now is, I think you got everybody on board. I know the medical board is on board. You've got a governor that's on the National Governors Association for prescription drug abuse. You've got U.S. attorneys that are involved. So there's potential to make wheels turn if everybody gets behind and pushes. I want to say, just sort of switch gears, and I'm going to say this, and I'm going to let Dr. Harrison speak. These are from the Department of Public Health prescription drug monitoring program, which was put in place to assist physicians and pharmacists. It's literally the final line to stop diversion. And that's where, when you go and get a prescription filled for a controlled substance, it's the pharmacist logs that into the database. And I, as a investigator with the board, can pull up any doctor in the state and look at what that doctor's prescribing. And in the past legislative session, we passed the pain management legislation, where doctors that are practicing pain management have to register with us. We made it easier for the doctors to use the PDMP. But in 2011, we talked about prescription counts, but in 2011, 218 million hydrocodone were prescribed in the state of Alabama. All right, 2012, 274 million. And in 2013, it was 342 million units of hydrocodone. That's just hydrocodone prescribed in the state of Alabama. So the board saw this, and we're put things into action to look at the physicians that are writing these things to try. The thing we have, which is a double-edged sword, is pain is real. And the last thing that I want to do, being a pain survivor, if you want to call me that, is someone who is in true legitimate pain be in pain because a doctor's scared to write him pain medication. On the other hand, I don't want somebody that's not in pain to get a prescription for pain medicine when they're not in pain. So we're treading, we have to go real easy because we don't want to cause more damage than good. And I thank y'all for letting me be here today.
I'm Jerry Harrison. I'm on the State Board of Medical Examiners. This is my 9th year. When I first started on the Board of Medical Examiners, I knew of a few physicians who were around me who were very easy to prescribe. But you've got to understand that we're not non-feeling people. If people come into us and tell us they're hurting, we have to believe them first. And like President Reagan said, you got to trust but verify. So if I have a guy who comes in and says, "Doc, my back's hurting, I'm just hurting all the time. You know, these 40 Lortab a month are not enough. I need more." And then he comes in to me or somebody comes in from another physician who's stopped writing for him, and he's getting 120 Lortab. Said, "Doc, my back hurts." I said, "Well, how'd you hurt your back?" "I hurt it playing football." I said, "When did you play football?" He said, "In high school." I said, "Hell, you 60 years old." You know, we have to look at this realistically. That this pain don't just stay there. We're responsible for it as doctors, a lot of it, because we're easy touches, because we want to help somebody. But we've got to use some judgment about it. Now, like, forget who it was, a while ago said Alabama likes to be number one, and we do. And we were number one in football for 4 years, but that pales in comparison to our prescribing. So I'm going to show you a little bit of history. This is Alabama. We're going to show you. In 1987, a group of us physicians, just were worried about hydrocodone, invited some people out to a place here in town. Now, I live 90 miles away, so I drove down for it. And we talked to them. I had a pain management guy and some other people talked about it. And they told us that in 1987, Alabama was #1 in hydrocodone. Okay, and we were, 87. But this data here starts in, what does that say, 99? Hell, we're still #1. Look at there. I mean, at 12 years.
I'm going to lower the lights a little bit.
13 and 14 years. Now, right here, in 2001, Nevada took us over. Okay? But that's from 87 to 2001, we were #1 in hydrocodone. Do the people in Alabama hurt worse than other people? Or do we just have a group of people who have been pretty easy about writing prescriptions? Okay? So you look here, the next year, Nevada, and there's a reason that Nevada got ahead of us. And you see there, it just went on. So we're going up to 2006. And there were 38.9 doses per person in in Alabama. In 2006, somebody said a while ago we were #2. This data is a couple of years old, said we were #5. But hell, we're still in the top 5. Okay, so let's go on to methadone. Now, a particular problem happened with us when people started using methadone for pain outside of the methadone clinics. And one of the points that I'm going to ask for in a while is there a way that we can get the methadone clinics to report to the PDMP? Because some of that medicine gets diverted. Diversion to us in physicians and on the Board of Medical Examiners mean I give it to you because you come and I write you a prescription, but then you give it to somebody else or you sell it to somebody else. That's what we mean by diversion. But here's methadone. Look at there. 97, nobody's writing this stuff outside of methadone clinics. 99, 2001, excuse me, in Alaska, I reckon right here, where it's cold, they started needing some methadone in 2002. But notice that Alabama's in there too. We're writing us some methadone because it's cheap and it's a strong narcotic. But people metabolize this differently. The pharmacokinetics of the pain relief and the pharmacokinetics of respiratory depression don't go hand in hand. So I have a saying, I said, the methadone you take for pain today may kill you tonight. So we've had a lecture series, Dr. Dole's and Mr. Rogers and a couple other of us on the Board of Medical Examiners have a lecture series that we've been asking physicians to go to who got in a little trouble with us. And part of the thing we've talked about is be very cautious about using methadone because you can't tell which ones it's going to kill, particularly if they put it with a little Xanax or a little alcohol. You know, it has a tendency for synergism off the respiratory depression, and it kills you. Okay, so there we are. Now, when Katrina come, every person from Louisiana that come through Haleyville, Alabama, was on methadone. And they couldn't get it down there because Katrina, so they come to, I thought all of them come to Haleyville, but as I talked to other doctors from all over the state, they all come to them and they was all looking for methadone. But when you get to 2006, we had 1.1 dose per person. We were number 7 in the United States in per capita in methadone use. Oxycodone, the same reason, the same prescribing pattern that we had for methadone. Not very many people wrote oxycodone. You know, I was a little scared of it in medical school. I was given a prescription of it when I had surgery, and I took one and I liked it. And speaking of that, let me just explain. Different people respond to medications differently. There's a qualitative and a quantitative difference in the amount of dopamine released from different people. And that's what makes those people vulnerable. They're more vulnerable. It's not because they're weak or morally decrepit. It's because it works better in their brain. The people who get addicted or dependent, they can tell you the first time they got exposed to it. It's like, well, life is right now. because they have a feeling that they've never had before. Those are the people that are vulnerable to dependence and addiction. And you can't do anything about that. It's about 1 out of 4, 1 out of 5 of us. And that's genetically predetermined. But anyway, nobody wrote oxycodone very much. And then, like Dr. Tucker said this morning, OxyContin come around. Now, what they told me, I'm a primary care doctor out in the country, and she was talking about we don't have a lot of training out there, just maybe some common sense. We're getting more training now. But they come out there and they say, now, this is oxycodone. It's a good pain medicine, and it is. It's a good pain medicine. But this version can't be abused. He didn't, the rep told me that he didn't realize how resourceful the people in Winston County, Alabama are. Those people learned how to grind it up, dissolve it up, and shoot it up in about a week. So then people started using it. There again in Alaska, must be a lot of pain up there, and in Missouri. And Florida. They were talking about the pill mills in Florida. There's a movie you can watch on YouTube called The OxyContin Express. And I encourage you to watch that. The guy who's the subject of it, who they're talking about, you know, his wife had died. He's dead too. He overdosed on oxycodone. But here is OxyContin. It's a good pain medicine, don't get me wrong. And now that it can't be abused so much, it's okay. I don't use a whole lot of it because I'm scared of it. I had a patient who's a VA patient, and some way or another they sent him back to me to write his OxyContin on a small dose, twice a day. Been on it for many years. No escalation of dose. Pill counts are okay. Urine drug screens are okay. But when they changed the formulation, he come to me, I don't like that new OxyContin. It broke my tooth. What that tells me is that he was chewing the other one up. But he had been righteous with it, no increase in dose and all like that over years. But he didn't like the new formulation. So in OxyContin in 2006, we were number 32. We couldn't afford it. It was expensive. So we couldn't afford it. We were number 32, but that's still 7.7 doses per person. Characteristics of drug abuse versus legal use. The intent, if the medical use is to treat a legitimate medical problem, that's okay. If it's non-medical, it's usually for a side effect, for them to get high, for them to get a buzz. The consequences, legitimate use is the standard. It improves the quality of life. Non-medical use typically leads to an escalation and a decrease in the quality of life. Controlled medical use, like I told about this person with OxyContin, uses a stable dose over a long period of time, doesn't get into trouble, urine drug screens are okay, pill counts are okay. That's medical use. Non-medical use, they're going to start losing it. The dog ate it. They got robbed. They got a police report. All the BS that we hear. Now, we as physicians have to deal with this. You know, people come in, oh, I lost my medicine. I don't know what I did with it. You know, I washed it. You know, I did this. You know, we've got to listen to that, and we have to filter that out. You know, and you know, it's getting to the point that our filters are getting tighter and tighter. They're micron filters now, and I just don't believe any of it. Legality, medical use is legal. Non-medical use, diversion is illegal. The pattern, medical use is stable without simultaneous non-medical use of other drugs. They can be taking their pain medicine okay, but if they're abusing other medications, alcohol, benzodiazepines, soma, with it, then that's not good. Addiction, nutshell, as I mentioned, it's a dopamine effect. It's how fast and how high it rises when you take it. It's a qualitative and a quantitative difference. Narcotic naive patients, this difference can be shown in as few as 4 days. Okay, these are just questions that we can ask patients. Have you ever hurt so bad you took more than prescribed? Have you ever borrowed? How long since you were pain-free? If people are addicting, they've never been out of pain in their entire life. You know, what makes it better or worse? You know, do you smoke a cigarette within 1 hour of getting up? Actually, that's a very important question. Because if they get up and they smoke a cigarette and they're taking pain medication and they have an escalating dose, they are at increased risk for developing abuse, dependence, and addiction. Drug-seeking patients, they come in when they're unscheduled. They took too many. Oh, the pharmacy shorted me. You see that? Those pharmacists just won't do what they're supposed to do. I had a prescription for 90. He only gave me 41. So, if they come in your office and pass out, if they come in and they're sitting there and they're so obtunded that they can't do anything, you got to start reassessing. We as physicians need to do that. We've got some other tools. But I heard somebody else say this a while ago. If you don't know how to land a plane, don't take off. If you don't know how to fly, don't take over. If you don't know how to say no, don't say yes. And if you can't get out of the relationship with your patient, don't get into it. You can't have confrontational phobia and deal with these patients. You're going to make some of these patients very pissed off at you when you tell them, look, you've got a problem. You're getting out of control with your pain medicine. We need to go in a different direction. So that's all I got to say about that. Now, I got a couple of comments on things that have been said today. Prescription forgery. Well, the federal government, in its infinite wisdom, allows us to e-prescribe through our electronic prescribing. But we got to write controlled substances out. It's hard for them to get into my computer system, which has got 2 passwords, get into my EHR, which has another password, and then prescribe with my password. But that's for non-controlled substance. For the narcotics, I got to write it out, give them on a piece of paper. And they go down to the local Kinko's and copy that up, make about 50 copies of it, and then they take it to different pharmacies. Now we can catch them with a PDMP. So if the DEA could hurry up about e-prescribing, that might help us. The BME will consider Narcan if somebody wants to suggest that. I've heard Deputy Attorney General Cole advocate for that. We'll consider that. When you talk about heroin overdose deaths, don't separate that from prescription drug overdose deaths. They're just as dead. So we need to address the addiction of these substances. Not only heroin, but the prescription medications, that needs to be addressed simultaneously. The VA and methadone clinics, I've already mentioned that. If we could get them to report to the PDMP, that would help us. And I'm glad we got the pharmacist up here, the pharmacy board, because if the pharmacy would buy in, if somebody comes in with a prescription and they look, they're 25 years old and they're young and look like they're real healthy, and they got a prescription for 450 OxyContin 30s, you may want to scratch your head and wonder, maybe the pharmacist can call this doctor and say, that looks like a little much. If the pharmacy sees people outside in their parking lot selling, they need to call the doctor. They need to be part of the solution. I have cameras outside my office. And I will tell you that I saw a young lady, wasn't that young, and she wasn't that much of a lady, but she ground up her medicine and she stuck up there on her thing and snorted it up her nose. Well, she had an interesting office visit that day. And she told me she didn't believe that, so we wound it back and we played a little video, and she left mad. Okay, we got to balance out, I've already mentioned this, pain control versus abuse. We as doctors, we as people who have controlled substance certificates, have to get involved and make sure that our patients are telling us right. Now, there's a new problem on the horizon. How many of you know what Zohydro is? How many of y'all are happy about that? Okay, well, the Board of Medical Examiners passed a rule that said, we don't want you to prescribe Zohydro in this state until you take a REMS course. That is a risk evaluation and mitigation strategy course put on by the Board of Medical Examiners that is specific for that medication. The company is really mad. They're coming to meet with us next week. But I'm going to ask this guy that's coming from the company if he knows about Alabama's particular involvement with hydrocodone. Massachusetts outlawed it. They filed suit against them, got a federal judge to stay that thing, so they can't do it. But it's here. They seem to be particularly happy that they do not have any deterrence problems, any deterrence stuff in with this Zohydro. The first person I saw who had taken Zohydro had ground it and shot it up. Okay? That's going to happen. This is the first time hydrocodone has been available in a way that can be abused IV. So that Opana was when it came out a couple of years ago. Y'all remember Opana? It became the new OxyContin because it could be diverted. Well, they took it off the market pretty soon after and reformulated, and it's not abused that much now. So just be on the lookout for Zohydro. Thank y'all very much.
One of the things that you all, each one of you have spoken about areas that we need to address, ways that we can address this issue of the pathway between pain management, prescription, to addiction. You've talked about alternative treatments, you've talked about training, you've talked about a lot of different things. I guess I would like each of you, if you could briefly just say, what's going to be the biggest challenge for our community in reaching some of those new solutions? What's going to present the biggest challenge?
It's the same thing, I think, that occurs in many places, and that is getting involved. This doesn't begin when people are 20, 21, 25. It doesn't begin just when they get a heroin. It doesn't begin when they get their first OxyContin. Oftentimes, especially from an addiction standpoint, you're talking about a predisposition, a genetic background, you're talking about a family history. There are many factors that play a role, and I think it's how to reach the parents of the young children, how to reach the young children, the 10, 11, 12, 13, 14-year-olds, how to educate them. When you understand the neurodevelopment, the brain doesn't develop to the point where it can make all of the necessary logical decisions until between the ages of 21 and 24. So our young folks are being bombarded with all kinds of things through social media, all kinds of decisions that their brains simply are not equipped to manage. They need help. They need guidance. They need direction. They need role models. They need some parameters within which to function until they get to where that brain can do what it's supposed to do. And right now, I feel very bad for all my children are much older than that, but I have grandchildren. I'm watching what they're being exposed to, and they need our help. So I think we have to elicit the help of families, of parents, of grandparents, of everybody trying to get to the youngsters, especially kids who come from vulnerable situations where there may be a bad home environment or where there may be indications of one or more parents or grandparents that have had substance abuse issues that make them vulnerable to abuse and likely to become an addict.
Thank you. Greg?
I think there are two major hurdles that I see, and one of them is just what we're doing here, and that is getting the community engaged and involved, which the organizers of this forum have been very successful in doing that. I think building upon that would be certainly the first thing that we need to do, and then the second would be, community outreach like you're talking about to the young folks and treatment of people that are already addicted, because if we limit the prescribing now, that's still not going to take care of the people that are already addicted to the medicine. So we really need to get out there and figure out ways to deal with the addicts that we already have.
Thank you.
Well, with pharmacy, I think the first step, you're going to have to get these associations on board. Just because the Board of Pharmacy may be for something doesn't mean these associations follow suit. In fact, our board right now is in South Alabama at Point Clear at the APA, the Alabama Pharmacy Association Conference. These pharmacists, and I'll just tell you, these pharmacists are more afraid of HIPAA. That if they could drive this home like HIPAA was driven home, this would be a different situation. These pharmacists are scared to blink if HIPAA is mentioned. Right. So I think you're going to have to get to these associations to get them on board, and I think once you do that, you'll see our pharmacists, I think, getting more training to deal with addictions issues, to possibly spot addiction issues and be able to deal with it. The pharmacists are just, they're asked to do so much. And I know you hear it a lot, and a lot of it, when you go to the pharmacy and you stand in line, you wait, and you think the pharmacist back there, they 20 to 30 insurance phone calls a day. They've got some technicians there, but I mean, they have to deal with the insurance companies on the phone. They have to call the doctor's office, try to verify. They have to take transfers over the phone. There's just so much that they're asked to do, and I mentioned earlier, they're already begging to have a cap put on the amount of prescriptions they can be allowed to fill in a day. They just don't have time, and until you get the corporations on board and these associations, then I think the pharmacy community, and I won't say that I speak as a whole for the pharmacy community, but if you could get those two on board, that would generate a lot of publicity for this problem.
Thank you.
I think the biggest problem that this is going to have is going to be, as long as it's not affecting this person or that person, they're not really concerned about it. I'm that way. I mean, I apologize, but that's, and most people are. As long as it's not involving us or myself, then it's not my problem. It's not the case. There's going to have to be something that's going to open people's eyes to become involved. One thing, speaking on as far as law enforcement, one thing that would help is there needs to be some training in the not narcotics, but in the first responder. When they get a call to a pharmacy and there's a forged prescription there, you can arrest that person, whether they get the drugs or they don't. You don't know how many times we get calls and the pharmacist has called the police department. The police department will put them in jail because the pharmacist didn't give them the medication. Well, that's not correct. They can be charged with that, and I think that needs to go on. There also needs to be some, with law enforcement and especially the medical board, if law enforcement goes to, especially in rural areas, they go to a person, unattended death, and there's pill bottles all over the place. I'd like to know the doctor's name. And if you pick up the phone and call me, I can look at the PDMP, and we make and build a case against that physician for whatever, whether it be overprescribing or for no legitimate medical need. That's just something I want to throw out there. But I think getting everybody to understand the urgency of this is going to be the thing to overcome.
Thank you. Dr. Harrison.
I am involved. A month ago, one of my nurse practitioners' brother died of heroin overdose. Not in Birmingham. He got the heroin in Muscle Shoals area, and he died in Nashville, but that was a month ago. So I am affected. I think more primary care doctors, if they learned a little bit about treating addiction with buprenorphine, Suboxone, like was mentioned earlier today, that is a good way to interdict from people going on and getting more and more dependent and more likely to become addicted and then segue into heroin. But also, as Edwin was mentioning, in rural areas, I mean, I had a 22-year-old couple who died a year apart. Now, they didn't die of heroin overdose. I suspect it was oxycodone, but they were signed out as heart attacks. 22-year-old, 22, 23-year-old. So we don't really know how many overdose deaths we have. And, it's expensive for them to do toxicology in rural, poor counties. they can't expend that money, you know, because the family's trying to come up with the money to bury the people, so that's a problem. But I will tell you that I fired a patient last fall because she just wouldn't be compliant. She left me and she went to another physician, and her daughter filed a complaint with the board about this other doctor giving her medication, and she overdosed and died. And so that's on our schedule for this week. Now this is the lady that I fired. I mean, I bent over backwards for her. I let her come back 2 or 3 times. She'd come in, she'd have cocaine and methamphetamine and this, that, and the other in her system. But you know, it's just too much drama, and I just couldn't handle it anymore. And so I told her, I can't see you anymore. Let her have a month to find another doctor, and she found another doctor. And truthfully, the amount that he gave her, that's not what killed her. She got that plus something else, and I haven't seen the toxicology report. But we've all got to be involved as physicians. Primary care doctors need to realize that this is just part of the cross that we must bear. We've got to try to help these people. We've got to learn enough about addiction and pain medicine to try to balance it. I think that all addiction medicine doctors ought to have to take some pain courses, and all pain doctors ought to have to take some addiction courses, because they become intricately involved, and you can't really treat one safely without treating the other.
Thank you. You know, I hope somebody is taking very copious notes, because as this group and others move towards action planning around this issue, I think we've already started outlining what some of the steps are that need to be taken, and thank you for that.